Saturday. So I'm going to talk a little bit about the role of growth-friendly surgeries in early onset patients, but not regular early onset patients, the ones that are with neuromuscular scoliosis. So we all know the definition of early onset scoliosis, which means that you're defining the disease according to the age and not according to the actual etiology of the age. So any curve, any scoliosis curve that appears before it differs in the literature, either you say before the age of 6 or before the age of 10, regardless of the etiology, is regarded as early onset scoliosis. And why is that important? The definition, it's important because we have to go back a little bit to physiology and to remember that the creation of alveoli is mainly up till the age of 5. It continues afterwards in a very slow pace. That's why there's this discussion whether or not we should define early onset scoliosis as the age of 5 or 6 or the age of 10, because it continues till the age of 8 or 10, but then in a very small pace. But the majority of the creation of alveoli is by the age of 5. And after which there is more of hyperplasia of the thorax and the alveoli than actual creation in number of alveoli. This is very important to remember. DiMeglio showed us all these growth charts, and Laurie Carroll from TSRH showed us the magic number of 18 centimeters that should be the thoracic height that we should aim to. If you have a thoracic height that is less than 18 centimeters, then you have a restrictive lung disease. And if it's done because you created a fusion, then it's a iatrogenic restrictive lung disease that you created. So our goal is to reach a height of at least 18 centimeters, the thoracic height. What is the natural history of early onset scoliosis? If it progresses, then because there's the ones that don't progress, but mostly they do progress. There's the constant progression, and there is an increase. It's not a cosmetic issue. Like some people think that maybe adolescent idiopathic scoliosis is only a cosmetic issue. Here, for sure, we're talking about a severe disease that can cause major morbidity and mortality due to alveolar hypoventilation, hypoxic vasoconstriction, pulmonary hypertension, and at the end stage it can cause corpus mortality and early death. So why do we want to treat these patients? It's because we want to control the deformity, to support the spinal column and the chest-lung creation and the development of the lungs. So we now know that the old dogma that said that a short and straight spine is better than a crooked one is not true anymore. So what are the treatment options? We spoke about that, and I'll go over that very quickly. We start with observation and conservative treatment, but usually when the underlying disease is neuromuscular, then these measurements usually fail. You may gain some time, but usually they fail. I'm not saying always, because there's never always in medicine, but usually they fail. What I use as a brace is the Garchois brace. It's a French brace which is very rigid. It doesn't aim to correct the deformity. It just aims to control the patient when he's sitting without causing any pressure, because these kids, if you create pressure on them, then you're in trouble. So it's a very rigid brace. It doesn't correct. It just supports the patient, and you can have the support on the pelvis. You can have even a chin support and a head support, and you can even have an open, and the most important thing in this brace is that it opens the thorax, so allowing the patient both, if he needs a gastrostomy, so it's easily achieved there, and also for the lungs to expand and the patient to breathe. And in these kids, don't wait till the end of growth. This is a major mistake that tells you that some people say, okay, he's very young, let's wait till he reaches the age of 13, 14 or so, because then you're causing a disaster. And we know that this is a paper from France showing that the days post-operative of ventilation are in respect to the vital capacity you had preoperatively. So you don't want to have these patients with a very poor vital capacity, because then once again, you're into trouble after the surgery. So what are the surgical treatment options? We know David Skagg's classification to the either guided growth, which can be the Sheila technique or the Lucas-Trolli. We know that there's the second option is the posterior-based distraction techniques, which can be growing rods or vectors. And we know that there's now a new trend towards the tension band, which is staples or tethering, but this doesn't, at least to my knowledge, it's not been used on neuromuscular kids, just on idiopathics. So I'll go through some examples. The first one is a 80-year-old boy born diagnosed with neuroblastoma, and he was born with a paraplegic. He had the tumor excised via laminectomy at D10 to L2. He had hypertension due to renal hypertension with chronic UTIs, and he had this curve of above 60 degrees, and this is how he begins to sit and notice that he's beginning to have pelvic obliquity. So at this age, we put him with magic growing rods, and we had an initial curve correction from 66 degrees to 23 degrees with a balanced pelvis. And after 4.5 years with growing rods, with the magic growing rods, we ended up doing the posterior spinal fusion with this result, with a nicely balanced pelvis and spine. Second example is age with a 6-year-old boy with nemaline myopathy. When I first saw him, he was already with assistant BPAP ventilation with a 130-degree curve. This is how he looks like, the guy with nemaline myopathy, and note the severe kyphosis that he has. So once again, put him in a growing rod, which was very difficult to control the kyphosis here. I always put these kids post-operatively in a brace for at least 4 months. And he's still going on with the growing rods. The third example is an 80-year-old girl. She's CP GMFCS4 with a 68-degree curve and a pelvic obliquity of 15 degrees. This is her X-ray. And once again, we put her on a dual magic rods. This time, the magic rods extends to the pelvis itself, like you used to do with any spinal fusion to such a CP patient. So, what kind of outcome measurements do we have to this patient? So, we know that in the literature there's a significant reduction. It's reported to have significant reduction in the deformity. There is inconsistent results regarding the effect on the pulmonary function. And don't forget, these patients are both very young and very sick and sometimes mentally retarded, and it's very difficult to have pulmonary function tests to these patients. So it's really very hard to compare truly and to measure these measurements, even though they are the most important measurements I think we have. You have to be ready for high rate of complications, both regarded to the implants and to infections. And you have to remember that these are very sick patients, and the nutritional status is very essential, and sometimes we have difficulties in that also. So, closing remarks. Are we really helping these young and sick patients? Personally, I believe that we are. But there is lack of good scientific evidence with long-term results regarding these patients. But currently, it's the best we can do. I want to end by reminding and inviting everybody that next year in April, the European Pediatric Orthopaedic Society annual meeting will be held in Tel Aviv, and it will be in the beginning of April. I think it's for sure. I will be delighted to see our guests from abroad there also, but I want to invite everybody to attend this meeting. I think it's very important that such a meeting is held in Israel, in Tel Aviv, and everybody is invited, the first week of April 2019. Thank you.